Hi everyone. So today we'll be discussing about ventricular septal defect. It's a very important must-know topic for PG residents and also for all practicing pediatrician because this is the most common congenital heart disease. So we'll start from ventricular septal defect. The content in this video is taken from the Park's textbook of cardiology. So we'll learn about the pathology, the types, clinical features, investigation and management of VSD. So VSD, as I said, is the most common form of congenital heart disease, which accounts for 17 to 37% of all the congenital heart diseases. Coming to the types of VSD, we have 4 types, which is the membranous, muscular, inlet, and the outlet VSD. So we will look at each of the types in detail. So coming to the membranous VSD, this is the most common type of VSD, which is a small area beneath the aortic valve. So you can see here, this is the location of the perimembranous VSD. It involves various amount of muscular tissue adjacent to the septum, and it can be called as membranous inlet VSD, membranous outlet VSD, and membranous trabecular VSD. So the second type is the outlet VSD, which is also known as infundibular or the coronal VSD. It is located at the coronal septum, which is formed by the aortic and the pulmonary annulus, and aortic leaflet can prolapse through this VSD and can cause aortic insufficiency. To infundibular VSD, we have to think of aortic insufficiency because the aortic leaflet can easily prolapse through this defect, and it is also known as supracrustal, coronal, subpulmonary or subarterial defect. So outlet or infundibular VSD, high chance of aortic valve prolapse, and it is also known as coronal, supracrustal or subpulmonary defect. Then the AV canal defect or the inlet VSD, located beneath the septal leaflet of the tricuspid valve. Then the muscular VSD, this can vary from tiny to large ones, and Swiss cheese defect when there is multiple hole in the muscular VSD, which is called Swiss cheese defect, and it is difficult to close surgically. So coming to the clinical manifestation of VSD. So we know that VSD most often presents after the 6 weeks after the pulmonary pressure falls. So most of the VSDs, moderate to large, are the ones which become symptomatic. Usually the small VSDs are asymptomatic and they have normal growth and development. The moderate to large VSD, they will show features of delayed growth and development, decreased level of activity, recurrent LRTA, and features of congestive cardiac failure. And long standing, this can lead to cyanosis and reduced pulmonary activity. Coming to the pathophysiology of VSD, so assume that this is a heart with 4 chambers. This is the atrial septum. This is the ventricular septum where you have the defect. This is the left ventricle. This is the right ventricle. We have pulmonary artery and we have the aorta, which arises from the left side. So pulmonary artery goes to the lung and the aorta goes to the systemic circulation. So what happens here is, whenever the blood comes from the pulmonary vein into the left atrium and then to the left ventricle, because the systemic vascular resistance is very high, the blood will shunt from the left to right. So what you can see here is a left to right shunt. But even after the shunting, the blood goes to the pulmonary artery and then to the lung and get purified. So because of this, there will be acyanotic heart disease, and there is overload to the right and the left ventricle. So both the right and the left ventricle is overloaded. The volume of shunt will depend on the size of the defect. So what happens eventually? So because of this constant overloading, there will be increase in the pressure that is developed in the pulmonary artery and in the lung, which will later lead on to pulmonary artery hypertension. So this is what is being discussed here. So through the VSD, there will be shunting of blood from the left heart to the right heart. So from this it goes to the lung. Then because of the overload in the right ventricle and the pulmonary artery, there will be soon development of pulmonary arterial hypertension, and this is called Eisenmegerization. So, small VSDs may not allow such a huge shunt to happen, so children will have a normal growth. Whereas moderate to large VSD, the shunt is very evident. So, what happens here? There will be pulmonary plethora, recurrent LRTI, delayed growth because of constant mixing of blood. There will be reduced level of activity and chances of congestive heart failure. And long-standing pulmonary hypertension will lead to cyanotic and reduced activity, which is as a result of Eisenmegerization. So coming to physical examination, what do you see here? You see an acyanotic heart disease. Large VSDs will have poor weight gain and CCF. Cyanosis and clubbing will happen in the later stages. There will be a systolic thrill which is present in the left lower sternal border. Precordial bulge and hyperactivity will be present, which is an indirect evidence of the right ventricular hypertrophy and the volume overload. S2 will be loud and single in patients with pulmonary hypertension. So how do you define a VSD murmur? A VSD murmur will be a grade 2 to 5 out of 6 holosystolic murmur which is heard in the left lower sternal border with an apical diastolic rumble. So coming to the ECG findings of VSD, we know that in small VSD, most of the time the left to right shunt may not happen, so the ECG will be normal. In moderate VSD, there will be left ventricular hypertrophy because the blood is coming back from the lungs, again back through the pulmonary vein and first loading the left ventricle. So there will be a left ventricular hypertrophy. When there is a large VSD, this shunt will be so much that the blood will cross from the left to the right side, and this will lead to biventricular hypertrophy. And on the later stages, the right ventricular hypertrophy happens. There will be pulmonary artery pressures going up, and then Eisenmegerization and pulmonary artery hypertension develop. So the typical ECG finding or the named ECG finding in VSD that we need to know is the Katz-Waschel phenomena. So Katz-Waschel phenomena is basically here the R wave deflection will be very high, amplitude of R wave becoming very high. This is because of the right biventricular hypertrophy. Then coming to the radiological findings, so whatever pathophysiology we have learned, because of the biventricular hypertrophy there will be cardiomegaly, because of the overflowing of the lungs there will be increased pulmonary vascular markings. In Eisenmenger, the main pulmonary artery and hilar pulmonaries will enlarge, but peripheral pulmonary fields are ischemic. Coming to the echo, 2D echo identifies the number, size and the exact location of the VSD, and cardiac valves will serve as marker for specific type of VSD. So because we studied about 4 different types of VSD, to know which is where, it is the cardiac valves that will help us to find which type of VSD we are dealing with. So coming to the natural history of VSD, so you know that most of the VSDs will close spontaneously. So the membranous and the muscular VSDs will close, and most of the time this happens as early as in the first 6 months itself. And a child can have spontaneous closure of VSD up to 8 years, but not after 8 years. Even a small defect in a child that is found after 8 years is unlikely to close. The second thing that can happen in a VSD is congestive cardiac failure. So you know that when the pulmonary pressures fall, which happens around the 6 to 8 weeks, there will be an increase in the left to right shunt, which causes flooding of the lungs and which will in turn lead to congestive cardiac failure. So I will show you a graph on how the pulmonary vascular resistance falls. So at the time of birth, the pulmonary vascular resistance will be very high. And then soon after birth, there will be some fall in the pulmonary vascular resistance, and then the maximum fall occurs after 6 to 8 weeks. So after 6 to 8 weeks, what happens is the pulmonary arterial resistance will be lesser compared to the systemic vascular resistance. So when this happens, there will be increase in the left to right shunt, which will lead to congestive cardiac failure. Then in large types of VSDs, there will be a reduction in the left to right shunt because of infundibular stenosis. Coming to the management of VSD, we have medical management and surgical management. There can be medical, surgical, and even non-surgical device closures. So coming to medical management, our goal in managing VSD includes three things. One is CCF prevention, second is the growth of the baby, and the other is iron deficiency correction. So first thing is the CCF. So you can give like the diuretics like Lasix and spironolactone, which is a potassium sparing diuretic. If there is AC inhibitors, you have to be very careful in giving potassium sparing diuretics. So diuretics used for 2 to 4 months to see the improvement in the growth failure. You can give frequent high calorie formula for growth failure and oral iron therapy. Coming to device closure is used for defects which is not close to the cardiac valve when it is difficult to access it through the surgical management, and it is not popular for perimembranous VSD because of the risk of post-procedure heart block. Surgical management, so the indication for surgery, very important. You can do surgery if the growth failure cannot be improved by medical therapy. VSD should be operated within the first 6 months of life, preferably by 3 to 4 months. If the PA pressure is more than 50% of the systemic pressure, surgical closure is done at the end of first year. After 1 year, a significant left to right shunt with QPQS ratio of at least 2:1, you need to do a surgical closure. Older infants with large VSD and elevated pulmonary vascular resistance has to be operated. The contraindication for VSD surgery is if the child develops pulmonary vascular obstructive disease, that is Eisenmenger syndrome, then you cannot do a surgical closure. Coming to complications, complete heart block, residual shunt, post-pericardiotomy syndrome, and bundle branch block are frequent complications of VSD surgical closure. The mortality because of surgery is 0.5%, and the mortality rate is way higher in less than 2-month-old babies when there is associated defects and multiple VSD. If you found this video useful, please like and subscribe to my channel for more videos on pediatrics. And if you have any doubts on this topic, you can mention it in the comments and I will be there to answer the questions for you. And if you want more videos from congenital heart diseases, you can mention that too in the comment section. Thank you and keep learning.